Okay. Um, so this is at request. I had requests the last couple of months for cardiac stuff along with pharmacology. Okay. So bear with me because there's no way to make pharmacology super interesting. I guess unless you're like a chemist. Um, so we'll get through it, but it was at request of somebody here. So, and then we're going to do, after the break, we're going to need one of the monitors so that way we can practice pacing because that was one of the requests is to practice pacing. So after the break, we'll do that. So, as always, whenever I do anything cardiac, I like to make sure that people are aware. I don't really truly have any disclosures to report, but I did go to the Resuscitation Academy, which is partially funded by Physio Control and Zoll. And I'm also a board member of the Ohio CARES Registry, which is the cardiac arrest registry that the state of Ohio uses and a bunch of other states use. Neither of these were paid. I do it because I'm passionate about it. So what we're going to talk about today is a little bit of the coronary anatomy, but this is not a STEMI lecture. Okay. Yes, we're going to go over STEMIs, but this is not an EKG lecture, in and of itself. Okay. We're also going to talk about the pathophysiology of some of these disorders, and then some of our treatment priorities for the various things that we put up there. Um, so cardiac disease is one of the leading causes of death every year in the United States. I believe last year and probably this year, respiratory diseases are going to be, above cardiac, which is unusual, but it's also because of COVID. I expect that as COVID, settles out and it's kind of the seasonal flu kind of thing, which is what I'm expecting it will be, that it'll go back to cardiac is one of the leading causes and pulmonary follows behind it. Okay. So if you have a STEMI, you have an in-hospital mortality of about 12%. So 12% of the patients that we transport having a STEMI are going to end up dying nationally. Okay. The total mortality is 27%, and that includes the folks uh, that die, before we get them to the hospital. We diagnose them with the STEMI, and they die before we can get them to the hospital. But it also includes the people that maybe get discharged to acute rehab or to a long-term care facility after their STEMI, and die as a result of the STEMI and its complications. 41% of patients that have a STEMI are going to develop heart failure at some point. That doesn't necessarily mean that they're going to have long-term heart failure, because again, if you have a STEMI, your heart's not going to be able to pump as effectively. And so you may end up developing heart failure while you're having the STEMI. But then your heart can recover, after you get your angioplasty and your stent, et cetera, and go on and have a completely normal life. Whenever we talk about STEMIs and EKGs, et cetera, we always need to kind of remember what exactly it is that an EKG tells us. An EKG is basically trying to create a 3D electrical picture of our heart, okay? And whenever you're looking at a lead, kind of look at it like it's a camera, okay? Except the difference is the camera is measuring kind of a distance, okay? So as something gets closer to the camera, it becomes positive. As something goes away from the camera, it becomes negative. Okay. So by being able to determine kind of where you are in space, you can then determine, okay, what artery is likely affected. The EKGs are basically divided up front to back and then top to bottom. And by doing that, we can then basically triangulate pretty much where the problem lies. Okay. And this is how it then shows up. So this is your typical 12 lead layout. The reason it's important for us to know, kind of which artery is likely affected by those leads is because it determines what initial treatment that patient may get. If we have somebody who's having an inferior MI, we know that they're more susceptible to developing, hypotension and also some arrhythmias. Same thing with septal leads. If they are having a septal MI, they're more susceptible to developing certain arrhythmias as well. It also helps the cath lab though. The arteries come off at different points. So typically your left coronary artery comes off of the aorta on the left side. And typically the right coronary artery comes off of the aorta over on the right side. So that means that you basically have to have two different hoses, those catheters, okay? So you have a catheter that goes up to the left side and a catheter that goes up to the right side, okay? If you call in and you say, I've got a patient who's having an inferior MI, the cath lab is going to know, hey, that's probably going to be his right coronary artery. 80% of inferior MIs are caused by a blockage in the right coronary artery. So we need to grab the equipment to go to the right coronary artery. Okay. Vice versa for basically everything else, you're going to be grabbing the left coronary artery supplies. So it does matter because they'll have everything prepped and ready. That way, as soon as that patient gets into the cath lab, they can get them, prepped, draped, sedated, and cathed as quickly as possible, but already have all the right equipment kind of sitting out and ready to go. So again, this is not an EKG lecture, but 2-3 AVF corresponds to the right coronary artery and posterior descending artery, okay? V1, V2, those are your so-called septal leads. That typically is going to be the left anterior descending. Okay, so you have your left main in most people, left main that then splits into your circumflex and your left anterior descending. So V1, V2 typically are a more proximal, closer to the top, LAD lesion. V2, V3, V4 are anterior. Okay, if you think about it, this is right where it is, which is the front. Okay, underneath that nipple. That also is going to be the left anterior descending typically, and is going to be further distal, okay? V5, V6, 1, and AVL, those are all your lateral leads, okay? Because now you're all the way out here, kind of in the armpit area. Those correspond more with the circumflex. Sometimes, though, people will have the circumflex kind of joining up with the posterior descending artery, and so it can be a little difficult when you're having these lateral MIs to know, okay, which side am I going to go with? And so sometimes we get it right, sometimes we get it wrong, and we have to pull the left-sided catheter out and put in the right-sided catheter so we can get at it from that angle. Some people, the circumflex actually comes off of the right instead. But this gives you an idea of where you need to go and kind of what complications are going to occur. So what are the risk factors for developing cardiac disease? Well, we know that high blood pressure, high cholesterol, smoking, diabetes, those are the big ones that everybody kind of thinks about. Age greater than 55 is an important factor, and male is an important factor. There's belief that the testosterone has some effect on it. Also, men tend to not take care of themselves as well, medically, and so they may have more advanced disease, than a female who may go and get checked out before she has the heart attack. Develops chest pain when going up and down stairs, goes get checked out, whereas a male may not do that and say, "Oh, I'm fine, I'm fine, I'm fine." Family history is an important thing. When I did my cardiology rotations as a med student and as a resident, I swear to God, those guys ate way more fried food than any other specialty. It was kind of also like pulmonology. About half the pulmonologists and respiratory therapists I know smoke. It's like you guys see the consequences of all this stuff, and yet you still smoke and eat fried food. And really, in sitting at lunch with these cardiologists, et cetera, they all pretty much say, yeah, the smoking, the high blood pressure, high cholesterol, that all plays a part. But a lot of it is genetic. You're either blessed genetically or you're cursed genetically. Okay. I had a case when I was a med student of this guy who his dad had died of a heart attack in his early 50s. His brother had had a heart attack in his late 40s. And so he said, I'm not going to do this. Of course, both those guys had high blood pressure, high cholesterol, smoked. I don't think they had diabetes. Okay. He said, I'm not going to let this happen to me. My dad died when I was young. I'm not going to let this happen to me. So he was vegetarian, he didn't smoke, he didn't drink, and he ran marathons. Okay. This guy should be the pinnacle of health, right? Yeah, had a massive MI at like 48. Okay. Did everything right, but he was just blessed, or I'm sorry, cursed genetically, that he just had premature coronary disease. We can now actually do DNA testing, so you can go get swabbed and get your DNA tested, and we can tell you about if you've got certain genes that predispose you to diabetes, high blood pressure, cholesterol problems, etc. It's crazy, and we're just scratching the surface of what we can tell genetically. So if you have family history, please pay attention to symptoms. Okay, even if you live a fairly boring life, I guess. All right, this slide shows us the plaque formation. Okay, you don't have to remember a whole lot from this, but I wanted to show you kind of how these things happen. All right, so we start off with this A right here, and you can see that there is kind of this little buildup, all right, of a little bit of cholesterol. So the inside lining of the piping is now beginning to get some kind of just debris. Okay. Then as that happens, the body recognizes that that's abnormal and it progresses over towards B. So you get this cholesterol deposit that's now there, and you've got cells that are going in and trying to essentially clean out and digest this cholesterol. And so they look like foam. I mean, if you look at that slide, you can see it's kind of foamy. It looks like it's got big pockets of air in it. Well, that's actually the cholesterol, the liquid cholesterol. And so the body is now trying to clean that stuff out since it knows it's not supposed to be there. During this time, you also are beginning to develop kind of the inner lining is beginning to develop a skin over this cholesterol deposit. Okay. To kind of help contain it. As it progresses to C, you're now beginning to get pooling of the lipids. So the cells aren't able to digest all of it. The lipids are building up even more. And so you get these pockets that are now even bigger. Okay. You then move down to D and E. Okay. And we don't yet really know who's at risk for which. Okay. This calcification occurs when it's a chronic thing. So you've got this chronic inflammation of the plaque. The body is trying to get rid of it. And whenever an area is chronically inflamed, the human body naturally wants to kind of dump calcium into it, turn it into bone. You can get the same thing that'll happen in muscles. It's one of the things that leads to arthritis, et cetera. But you'll get these calcifications, and it's kind of interesting. Sometimes we'll get, just a plain chest x-ray on somebody at the hospital, and you can actually see their coronary arteries because they are literally that calcified that you can pick out the tube. It's a little frightening. These fibrous capped ones, though, the D, those are the ones that are more concerning. Those are the unstable plaques. They haven't calcified down, okay, but they're unstable. They have this necrotic core, so now you've got so many lipids in there that the cells that are there don't have a blood supply, essentially. And so now they're beginning to die off, and you're getting even more inflammation. Eventually, what happens is this plaque is going to rupture. When that plaque ruptures, that's when you have a STEMI. Okay. So E is the guy who develops chest pain when mowing the lawn. They stop mowing the lawn, maybe take a nitro, their chest pain goes away. Okay. D is the person having the STEMI. Okay. Whenever there's a cut in the human body, clotting is going to occur. So when this plaque ruptures, the body views it as the artery has ruptured. So it's going to begin to clot off that area to try and keep blood from spilling out wherever it's going to go. And as a result, you not only have this narrower spot because of the cholesterol deposit itself, but now you've got clot that's beginning to fill up that narrow spot, trying to block off what it views as a cut. Okay, I'm losing blood through this artery now, so I need to heal it up. That's when you get the STEMI. So there are a couple different ways that we classify MIs. The one that we care most about is this MI type 1 at the top. And that's when you've got a plaque, it ruptures, you develop a blood clot, okay? The treatment is we diagnose it first, we go in and suck out the clot, or pass a wire through the clot and then put a balloon down and balloon open the artery, and then eventually put a stent in there to help keep it open, okay? At the same time we're doing that, we're giving them all kinds of platelet inhibitors and blood thinners to keep their blood from reclotting. Because even when we put that stent in there, that stent is a foreign material. The body is going to recognize that as a foreign invader, and it's going to cause clotting. So you have to give them these blood thinners and platelet inhibitors, et cetera, to keep that blood clot from occurring. The first kind of 3 months after somebody gets a stent, they're at risk of developing an in-stent restenosis, is what it's called, which is basically they develop a clot again, and now that stent is bad. They have to go in and possibly put a stent over a stent and tell the patient you really need to take your meds the way you're supposed to. Okay. These type 2 MIs are less common, for us to encounter, but essentially we've got flow issues. So the MI type 2, right here, the vasospasm, that's the kind of thing that we expect to see after somebody is using cocaine. Okay, so somebody goes out on a cocaine bender, cocaine causes all kinds of vasoconstriction, and so now all of a sudden their coronary arteries are too small to supply the oxygen that's needed to the heart. So the heart kind of takes some widespread damage, okay? The second one down, the fixed atherosclerosis and supply-demand imbalance, that's the kind of thing that we see when somebody has, these plaques that probably are stable, all right, but they severely limit the blood flow. And now this person, is under some sort of stress. There's a hurricane coming. They've overexerted themselves, putting boards up on their house, et cetera. They develop chest pain, but they're not truly having a STEMI. It's because their heart was working harder than the piping could supply blood to it, okay? It's the same thing that happens in this last one, the supply-demand imbalance alone. The difference with that is you've got a normal artery, so it's nice and wide open, but you're overexerting yourself for what that artery can supply. So we will actually see this sometimes in like marathon runners, et cetera. They've done studies on folks that do that and ultra marathons and these really big exertional things. A lot of those patients actually have detectable troponin out in their bloodstream. They're overexerting their heart so much that some of the cells are getting damaged and or dying. So that's my reason why I don't run marathons. Anyway. But the one that we care most about in EMS is this plaque rupture with thrombus. So what are the symptoms that lead us to think it's acute coronary syndrome? So the classics are, chest pain and pressure, shortness of breath, nausea, vomiting, arm, neck, jaw, back pain. The one that doesn't get mentioned enough is my experience has been elderly females especially don't develop those symptoms. They tend to come in with, I don't feel good, or I'm fatigued, or I've got nausea, vomiting, abdominal pain. Okay. That's why it is so important to get, when you have somebody, especially with like upper abdominal symptoms, to get a 12 lead, because some people will present with abdominal complaints primarily. Part of that is because, if you think about it, your heart is basically sitting right on top of your diaphragm. And so you may get some referred pain down into the abdominal area. Plus, it shares some nerves with that area as well. Another one is diaphoresis. I always like to point that out. To me, diaphoresis is one of the physical signs that can't really be faked. Okay. I suppose if you're like a Tibetan monk and have trained yourself on how to, sweat on demand, okay, maybe that person can make themselves sweat. But most of us don't have the ability to say, I'm going to sweat. So somebody that's sweaty and they're not supposed to be sweaty, you really need to pay attention to, because that typically, in my experience, means something really bad is happening. There's also this feeling of impending doom that some patients will talk about, and I'm sure we've all had that patient who is really sick and says, "I'm going to die. I'm going to die. Oh my God, I'm going to die," or, I really need to go have a poop before you guys put me on the stretcher. Okay, anybody that needs to poop who's sick, that may be their death poop. Okay, so please watch those folks carefully. Sometimes it's better to just simply say, "Can you hold it till we get to the hospital?" Okay. But at the very least, if they have to go, make sure that you're right there by the door, that they leave the door unlocked so that way you're not having to bust the door down to get them when you hear them crash to the floor. So, so how do we diagnose a STEMI? Well, EMS can really only do it, in the first two ways. So they've got symptoms that are consistent with it. Okay. You look at somebody and you're like, yeah, you're having a STEMI. Okay. And then 12 lead EKG showing that they're having a STEMI. At the hospital, I've got the benefit of doing, lab work and pictures and watching these patients for a much longer period. So at the hospital, we can do lab work that shows troponin elevation. Now, some systems are now doing point of care troponin testing in the back of the truck. And so in some systems, you'll actually draw blood and do a point of care troponin test in the back of the truck and be able to show up to the hospital and say, here's their EKG, here's their first troponin, which is pretty cool. It's also expensive as heck. They've got to have imaging consistent with an MI. So that means that we've done an echo that shows that part of their heart isn't working, or we do a stress test and take the pictures and there's low blood flow, or we do a cardiac cath that shows something. And then again, because we have the luxury of watching these patients for time, we've all seen, kind of the progression in the textbooks of, this is what a STEMI looks like at the beginning, and this is what it looks like 3 weeks later, et cetera. The so-called queuing out of a heart attack. We will see that happen at the hospital as their EKG, those ST elevations will slowly become less pronounced, and they'll begin to form Q waves where that scar is. So that's findings consistent with it as well. So this slide shows the AHA's diagnostic criteria for a STEMI on an EKG. Okay, it's fairly complicated. I mean, I don't want you guys to remember, well, it's got to be this many millimeters in these leads, et cetera. If you've got somebody who looks like they're having a STEMI, talks like they're having a STEMI, and has some sort of ST elevations, if you don't call it a STEMI, at the very least, transmit it, call into the hospital and say, I need you to look at this EKG and tell me what we got going on. Okay. We're pretty accurate though, in the field, in my experience. Because I try and review a lot of the EKGs, and I think we're pretty accurate. Whenever we've got somebody who's truly having a STEMI, we are right on. And I've really only had a couple where it's like, I wonder what they found at the hospital. So don't think that you have to memorize this chart. Just remember, if they look like a STEMI, they're acting like a STEMI, and they've got some sort of ST elevation somewhere, it might be a STEMI. So activate. So again, this is not an EKG lecture, so we're just going to breeze through these. So this is an anterior STEMI. You can see that the ST elevations are the most pronounced, kind of in V2, V3, V4. All right, and then we've also got some reciprocal changes out here in lead 3. And you can make an argument that maybe there's a little bit of reciprocal depression in AVF. This is a septal MI. So you could make an argument with this one that it's maybe an anteroseptal MI because there's ST elevations in V1, V2, but to me, V3 looks like it has the highest ST elevations. So this probably is more like an anteroseptal MI. You've got reciprocal changes out in 2, 3, and AVF as well. Also, you've got a little bit of ST depression in V6. So this is a lateral MI. So you can see, yeah, okay, there's maybe a little bit of ST elevation here in V5, maybe a little bit in V6, but really where you see it is in 1 and AVL. So this person is having kind of a distal left main, heart attack or possibly a circumflex. okay? And then you see big ST depressions in the inferior leads as well. And then the classic inferior MI. Inferior MIs are 40% of all heart attacks. So if you need to pick something out, you need to know what an inferior MI looks like. So, you know, we've got ST elevations in 2-3 AVF, and then we've got reciprocal changes here in AVL, a little bit in lead 1, et cetera. Posterior EKG. This is something that sometimes gets glossed over in medic school. Posterior EKGs are basically your left anterior descending or your circumflex is occluded now on the back side of the heart. Okay, so if you think about it, V1, V2, V3 sit on the front. Okay, so if we see ST depressions here, okay, it means the electricity is traveling away from us. If we were to reverse it and put V7, V8, V9, what are we going to see there? We're going to see ST elevations, right? Because that same electricity is now traveling towards those cameras. So that's where you will get ST elevations in V7, V8, V9. So if you have somebody that is having these ST depressions in V1, V2, okay, V3, that's an indication that this may be a posterior STEMI. All right. So what you should do in a situation like that is essentially flip the EKG around and you take V1, V2, V3 off, okay, and put them basically V7, V8, V9 and just continue around to the back. Then you will see your ST elevations most of the time.
Is it only diagnostic when they have elevation? Is that why?
So it depends on who you talk to. So some people may be bullnosed and say, you know, well, it's not a STEMI because it's ST depressions, even though it's simply you change the EKG and now all of a sudden it's a STEMI. Most posterior STEMIs are also not going to be this apparent, where it's like, oh yeah, there's something real bad going on here. Okay, it sometimes is, you know, maybe 2 boxes, you know, and so those are the ones where it's like, maybe I better do a posterior, and then, you know, hopefully the posterior shows, oh yeah, that's definitely 2 boxes because you're a little closer now. The other poor man's way of doing this is to basically flip your EKG front to back, okay? And now if you look at it basically on the back side, you hold it up to paper and you can look at it from the back side, you'll now see, oh yeah, that's ST elevation, okay? Because that's essentially all that you've done when you change those leads. I wouldn't diagnose somebody with having a posterior MI by flipping the EKG upside down, you know, front to back, but it definitely should prompt you to maybe do a V7, V8, V9. Okay. Similarly, there is a right-sided EKG. I find this to be less beneficial simply because at that point, you're now wrapping around kind of the posterior aspect over there. Typically, though, you're going to see the ST elevations in the inferior leads as well. This just kind of tells you that, oh yeah, they're having issues even further down in that posterior descending or right coronary artery. And essentially, all you do is do a complete mirror. So instead of having V1 start on the right side of the sternum, you have it start on the left side of the sternum, and you just march your way out exactly the way. But you've got to label it. This one they did not do what I would say is the right thing because they only started with V4. But you should put on the top right-sided or circle the V1 and put V1R to indicate that this is a right-sided EKG and you can't interpret it like it's a normal EKG. Okay. So what are our treatment goals when somebody's having a STEMI? Well, we really want the EKG done in less than 10 minutes from the time we arrive on scene. And that means getting it in their living room, getting it where they are, you know, as long as it's appropriate. You know, obviously I'm not expecting you to expose somebody in the middle of Kroger, okay? But if it's someplace that's conducive to semi-private, try and get that 12 lead EKG where they are. so that way we can activate from where they are. In my opinion, it's perfectly appropriate for EMS to call ahead to the hospital while you're standing in somebody's living room and say, Medic 86, I've got inferior STEMI, ST elevations in 2, 3, and AVF, and a 58-year-old male. Don't have any vitals. We're working on getting packaged up. I'll give you a call back here in 10 minutes. Okay. Because that's an extra 5 or 10 minutes that now the cath lab has to come in from home if they're at home, or they may be getting ready to put a planned cath on the table. Okay. Well, if they have already started on that patient, they've got to finish that patient before they can get the STEMI onto the table. So if you call ahead, you may catch them in that period where they haven't started doing anything, but they're still getting the patient kind of prepped. They'll take that patient off the table and get it ready for the STEMI over the person that they haven't started on. So that extra time really does matter. It's not as big of an issue for us around here because pretty much everybody is a cath lab capable facility, but transport to a cath lab capable facility, obviously activate early, give them aspirin, 324 milligrams, PO chewed. Question I get asked very frequently with this is, Doc, what do I do if they take aspirin every day? You give them aspirin. I would go ahead and give them the 4 baby aspirin and have them chew it. If you're on daily aspirin therapy, you begin to get aspirin resistance. And so we've got to overcome that by giving you more aspirin. You kind of become tolerant to it, okay? If dispatch told them to take aspirin and they did, that's fine. But just document somewhere in the chart that they took aspirin prior to our arrival, okay? So that way I know what to look for, that, oh, okay, that's why they didn't give any aspirin. But it also helps the hospital. Somebody having a STEMI has to have had a dose of aspirin in the first 24 hours of their arrival at the hospital. If you guys don't put it in your report and the people in the ER don't put it in their documentation that EMS gave aspirin or that the patient took aspirin prior to EMS arriving, guess what suddenly is not going to happen? It's as if they never got aspirin, even though you may have told them at the bedside, oh yeah, they took aspirin before we got there. And so that's why nobody gave it. But if it's not documented somewhere, the hospital gets dinged. Some places around the country are doing Plavix. So if you've got a clear STEMI, they'll also have you take Plavix, which is another platelet inhibitor. Nobody around here is doing it. I've never worked in a system that really did that. So you can give nitroglycerin for pain control, but we're going to talk about that here in a minute. Obviously not in an inferior MI. Excuse me, I got a tickle. Excuse me. It's adorable. Thank you. I'm here all week. You can give morphine or fentanyl. We're going to talk again about that here in a little more detail. Oxygen to maintain their SAT, 94 to 99%. The goal now is first medical contact to balloon in less than 90 minutes. Okay, so that means from the moment that we are medical, from the moment we arrive on scene to the moment that the balloon goes up, we've got 90 minutes. That's not, oh, we have a full 90 minutes. It's no, we want to make it as short as possible in that 90 minutes. But nobody gets dinged as long as it occurs in that less than 90 minutes. That used to be less than 120 minutes. And now it's been moved down because we got so good at doing this. It also used to be that, door to balloon times had to be less than 90 minutes. They've now lowered that to less than 60 minutes because we're trying to push that envelope. We know that as little as 5 minutes difference in getting the balloon up in some patients may mean the difference between them running marathons again or them being a cardiac cripple with congestive heart failure for the rest of their life. We don't yet really understand why some people are that sensitive, and we don't know kind of what their risk factors are, so we can pre-identify those patients and go, oh, we need to get this balloon up now. But a small segment of the population, that 5 minute difference literally could be the difference between a normal life and a pretty miserable life. Question.
How would you like the patient handled that tells us they can't take the aspirin because they have an allergy to it?
So in that situation, I think it's appropriate for you to just simply document patient refused aspirin secondary to allergy, and then let the hospital figure out, like, is this really an allergy or is this you just got an upset tummy with it? It's like upset tummy gets trumped by you're having a heart attack. So, but I think it's appropriate for us as EMS to pawn that off on the hospital and just document, we didn't give it, patient said they have an allergy, or patient won't take it because they said they take aspirin every day, but just document something for me so that way I can see and the hospital can see, okay, they really did try. Because patient refusal, sometimes we will have the same thing happen at the hospital. Patient refusal excludes that patient from that core measure at the hospital level. And so the hospital doesn't get dinged because they don't have control over it. So,
They're allowed to refuse too, just to refuse, correct?
yeah,
Okay.
yeah. All right, who's this? Mona Lisa, okay? How many of us had shoved into our brains from a young age, Mona, morphine, oxygen, nitrates, aspirin, right? Okay. Well, by the end of these next few slides, I'm hoping that you walk away with okay? Mona isn't everything she's cracked up to be. So let's start with morphine. We know that if we give morphine to somebody who's having an inferior MI, it increases their mortality. Those patients die at a higher rate than patients who did not get morphine. Okay. The thought behind giving morphine in the first place is STEMIs are painful. All right. If you're having a STEMI, you're in pain, which means your body is now doing the whole flight or fight response. So your adrenal glands are dumping all kinds of epinephrine into your system, which is constricting down your blood vessels. Okay. Which is causing worsening, cardiac output, et cetera. So if we give you morphine and relieve your pain, you'll be under less stress and not have maybe as much epinephrine circulating around and maybe dilate your blood vessels a little bit. Okay. So that's the thought behind it. Right now, we've got studies on morphine. Okay. I'm not aware of any conclusive evidence yet that fentanyl does the same thing, but I've got to think that it probably does. I'm hoping that people are working on some studies right now, kind of looking at morphine, Dilaudid, potentially ketamine, et cetera, for use in STEMI to figure out, is this same problem occurring with essentially any opiate? But right now we know morphine in an inferior MI is bad, okay? We do know that overall, we give morphine. Overall, it doesn't decrease the effect of the STEMI. Okay, they have the same outcome whether they got the morphine or not, and it doesn't increase or decrease their mortality. So it doesn't really have any clinical benefit either. Okay, and that's not to say that reduction of pain isn't something that we should be concerned about. It's just it's not going to change their overall how well they do after their STEMI, or how likely they are to die overall, except in the inferiors. We do know that whenever we give morphine, it does reduce the absorption of some of the acute coronary syndrome medicines like aspirin and Plavix. So there's some thought that we probably shouldn't be doing it for that as well. All right, this is a busy slide. This is your oxygen and hemoglobin dissociation curve that hopefully everybody has seen at least at some point. All right. Essentially what we're looking at is the bottom x-axis is your oxygen partial pressure. Okay. So this is how much oxygen we are delivering to you. Okay. And the y-axis, the up and down axis, is the oxygen saturation of your hemoglobin, your basically your pulse ox. Okay. What it shows is that, once we hit roughly 90% or so pulse ox, we can dump all kinds of extra oxygen on the person. Okay. I mean, you look, we go from, roughly what we'll say 70 just to make it easy, a partial pressure of 60 or 70, and we dump all the way up to 140. So we double the amount of oxygen that we're giving that person. And look at it. They're really only going up by a small amount. Okay. Basically, what this is showing us is once you hit kind of 90%, there's not a whole lot of extra oxygen that your body can actually carry around. But if you're, 80%, okay, or I'm sorry, 80% over here, look at how much more oxygen you can carry by the time you get up to 90. A lot. So there may not be any clinical benefit to dumping all this extra oxygen on the person. Once your hemoglobin is fully saturated, where's that oxygen going to go? Yep, it's going to create free radicals. So it gets absorbed by your plasma, okay? It gets dissolved just like carbon dioxide gets dissolved in your carbonated beverage, okay? It's going to get dissolved in your plasma. When it's not bound by the hemoglobin, it can still react with other stuff, okay? And so that's where you're going to get free radical damage. Okay, so hopefully this is at the point where you've reached rock bottom with all the boring stuff.
I have one question.
Yeah.
I sat through a class a while ago, and it said they were really pushing end-tidal CO2s,
Yep.
even on MIs,
Yep.
because you put a pulse ox on somebody's finger, and it might say 90, but centrally they could be 60 because of how long it takes to circulate.
Yeah,
What do you think about that?
So end-tidal I love end-tidal CO2, but end-tidal CO2 really isn't going to tell us anything about their oxygenation. It will tell us about their perfusion, but it won't tell us anything about their oxygenation. It would be unusual for somebody to have a finger pulse ox of 90 and a central pulse ox of 60. Usually it would be the opposite because the body's normal response whenever it's in a low perfusion state is to shunt as much of the blood towards the organs. And so typically you begin to constrict down the extremities and even parts of the gut and stuff to try and preserve, the liver and the kidney and the brain and the heart, et cetera. So typically it would be kind of the reverse. All right. So we've got some good studies that have been done out there now on what oxygen does. So this is an angiogram of somebody who at rest has the left side. All right. So we see they've got pretty good contrast flow. They got a couple tight areas, but pretty good contrast flow. We take the same patient and put them on put them on 100% oxygen and look at how much reduction in blood flow they've got. Your body is amazing at being able to basically deliver just the right amount of oxygen and glucose and such to your tissues. So if it detects that it's getting way too much oxygen, it's going to begin to constrict down to reduce the oxygen flow because it knows I don't need all this. It may be somebody else in the body needs this oxygen, but I don't need all this. So I'm going to spasm down a little bit to reduce the blood flow so I'm only getting the amount that I need because it could be somebody else needs the rest of that oxygen. So as you can see, it spasmed down this guy's coronary arteries. And now you can see, look, he's got some pretty significant stenotic areas here that are probably going to need angioplasty. Okay. So there was a great article done in 2017 published in New England Journal of Medicine. Most of us consider the New England Journal to be the best medical literature that's out there. Okay. So when they say something or publish something, people pay attention worldwide. All right. So pretty simple study, oxygen therapy in suspected acute MI. This was over in Sweden. They measured approximately 6,300 patients, 2/3 of which arrived by EMS. So essentially they either got room air or they got high flow oxygen. Obviously, if they were, hypoxic to begin with, those patients were going to get oxygen. Okay. But if you had normal oxygen concentration, normal pulse ox, if you didn't need the oxygen, you weren't going to get the oxygen. All right. And so what happens is they measured out what happened, and no difference in their peak troponin level. So no difference in how bad their heart attack was. At 30 days, there was no difference in mortality, and there was no difference in readmission for another MI. The same finding held all the way out to a year. Okay. So their conclusion was there really wasn't any outcome benefit in providing oxygen. So the takeaway from stuff like this is, we've got some studies now that show that oxygen may be harmful when it's inappropriately used. So we're trying to target 94 to 99%. Okay. As long as you get to that 94%, you're good. We don't want you to get to 100%, because then you can't tell, are we just barely 100%, or are we blowing 100% out of the water and now we've got all this stuff in the plasma? So give them just enough oxygen to get them 94 to 99%. Okay. Nitroglycerin, explosive news. Because nitroglycerin can blow up. Roadrunner. Okay. So nitro may be harmful. One question that I've been asked before is, well, doc, we should keep giving them nitro even after we get their pain improved, to help dilate out that artery. Unfortunately, that's not how STEMIs work. That clot that is formed is more like a jello consistency. So if you dilate that artery more, guess what? That clot is going to dilate with the artery and is going to continue to plug it up. You cannot give enough nitroglycerin to reperfuse somebody. Okay. So it's good for treating somebody who has angina. It still is decent for treating somebody who's having a STEMI, because it may help dilate the coronary arteries around the heart that are not occluded, okay, and potentially provide some blood flow there. We know that there is benefit in severe hypertension if you're having an MI, or severe hypertension if you're having acute pulmonary edema with an MI, essentially making it easier for the heart to pump. If we drop your blood pressure a little bit, it becomes easier for your heart to pump, which means your heart's not using as much oxygen, which means it needs less blood flow. So it may have some benefit in those patients who are like 180 and above, all right? But obviously in an inferior MI, bad thing. If you give nitro to somebody in an inferior MI, it can be very dangerous. So you guys have access to the sublingual nitroglycerin, right? Sublingual nitroglycerin is 400 micrograms, okay, 0.4 milligrams. If you divide that out, we typically give it every 5 minutes, right? So 400 divided by 5 is 80. So you guys are essentially giving them 80 micrograms per minute of nitroglycerin. And it's a all or none. It's not, oh yeah, a minute into this, their blood pressure drops, so I'm just going to take the rest of the tablet out. It's not how it works, okay? So you guys don't have the ability to turn off and on nitroglycerin. I at the hospital will still sometimes, in some patients, use nitroglycerin drips in inferior MI, because I can go as low as like 2.5 micrograms, okay? So I'm giving them just a whiff of nitroglycerin to help reduce their blood pressure some. But if we give somebody who's having an inferior MI nitro, we potentially are going to just completely trash their blood pressure. And the reason for that is nitroglycerin doesn't just dilate your arteries, it's dilating your veins as well. The right side of your heart is dependent on blood flow coming back through the vena cava to fill it up so that it's got enough blood to pump through the lungs that then have to then fill the left side of the heart and get pumped out to the rest of the body. If we dilate out the vena cava, we've now essentially enlarged the pipe with the same amount of pressure, okay? So now all of a sudden the blood flow is significantly reduced. So less blood is now coming into the right side of the heart. If there's less blood in the right side of the heart, there's less blood that's going to eventually make its way over to the left side of the heart, which means it's not going to have enough blood to pump around either, and so their blood pressure tanks. Okay. So that's why we have such hesitation about giving nitroglycerin in an inferior MI. So what's our conclusion from all this stuff? Well, aspirin is about the only thing that we've got really good evidence that it is of benefit. Aspirin is about as effective in reducing death as cardiac catheterization is. Okay, about 23% reduction. So we're kind of now back to all right. So aspirin. So we know morphine's harmful in inferior MIs, may have slight to no benefit in other MIs. We don't want to give oxygen unless their pulse ox is less than 94% because it could be harmful, but we need apparently the dog doesn't like it. Yeah. So nitro doesn't really have any clear benefit either, and we know could be harmful in an inferior MI. But aspirin has clear morbidity and mortality benefits. So give them aspirin, get them to the cath lab. Okay? So we've been at it for about 45 minutes, so let's go ahead and take a quick break. All right, so let's talk a little bit about some of the arrhythmias. So bradycardia, defined as a ventricular rate of less than 60, only really requires treatment if the patient is symptomatic. All right. A lot of people walk around with heart rates that are less than 60 and don't know it. Okay. A lot of elite athletes have resting heart rates in the 40s. So if they're not having symptoms, it's okay. Their heart is just more efficient at pumping blood than the average doc. Okay. What matters is they become symptomatic. So they pass out. They feel like they're going to pass out. They have low blood pressure. They have altered mental status. They just look horrible. They have chest pain. They may be short of breath, etc. That's different. That requires treatment. So initial treatment for that is you've got to get a 12-lead EKG to kind of figure out what are we dealing with. Is this a sinus bradycardia or is this one of the blocks? Okay. The other thing that can happen is, it could be the person's having a STEMI, and if they're having a septal STEMI, it may be that they've got a block that's occurred because their AV node blood flow has been knocked out. Okay. While you're getting the 12 lead, make sure and get pacer pads on them, even if if that's not what you're going to do first. It's still a good idea because these patients can change very quickly, and it's better to have the pads on. Okay. So if the person is having a STEMI and they're bradycardic, call medical control first, because we may have you just watch it, okay, as opposed to needing to do more. The reason is, especially if you begin pacing it, that in and of itself is going to cause ST elevations. And so it can sometimes make diagnosis a little more difficult for us. Because once we start pacing them, those ST elevations can sometimes take a bit to go away. So this is where we get into the pharmacology that I promised you guys. So atropine is one of the first drugs that we're going to use for this. It's a muscarinic acetylcholine receptor antagonist. Everybody know what that means, right? Basically, what it's doing is it's overcoming the receptor. Okay, it's stripping the acetylcholine off. So what happens is in very low doses, it can actually cause bradycardia in and of itself. In super high doses, it has toxic effects like tachycardia, dryness, flushing, altered mental status, etc. It's really got two phases of elimination. The first one is the one that we really worry about, which is the rapid. So it's less than 2 hours, although honestly, atropine, its clinical effects are worn off well before the half-life has been hit. And then it's got a second phase of elimination, which happens about 13 hours later. So the dose for the longest time was 0.5 to 1 milligrams every 3 to 5 minutes. AHA in 2020 updated that. It's now 1 milligram. period. Okay. So 1 milligram every 3 to 5 minutes as needed for symptomatic bradycardia. Okay. You can consider doing push dose epinephrine if the person is unresponsive to the atropine. The epinephrine in and of itself is going to stimulate the heart, and so hopefully increase their heart rate some. Plus, if they're hypotensive, it may help develop a little bit of a better blood pressure. Sometimes patients are hypotensive first and then become bradycardic, and again, that's probably because they have a low blood flow state, so their AV node isn't functioning as well. Their SA node may not be functioning as well. So typically with these folks, we're also going to be giving them IV fluids, as well. So we get to the point where we're needing to pace now. So we've tried atropine, we've tried push dose epinephrine, or we've got somebody who is getting ready to arrest and we don't have time to see if drugs are going to work. We go to pacing. If we can, we try and sedate people before we do that. Okay, we give them morphine. I'm sorry, not morphine, Versed. I want to say it's 4 to 8 milligrams intravenously or intramuscularly. I think it's written. It's 2 to 4. Isn't it? Isn't it up to twice though? I think.
It's a max of 8 milligrams.
Yeah. Okay. So basically give them some Versed, all right, and then start pacing. So we're going to have a practical session on that here in a minute, but essentially the way you start pacing is you, of course, get your pads on, tell the person that you're going to have to do this and that it's going to hurt. All right. Try and give them that warning. And then what you do is you put it over into pacer mode. On the physio controls, you hit the pacer button. Okay. It starts off at 0 milliamps and it usually defaults usually at around 60 beats per minute. Okay. So I usually will start them more like 80 beats per minute. Okay. Because I'd rather them be a little fast than a little slow. And then you slowly start turning up the milliamps. So you're going to go by roughly 10 milliamps of energy every 5 to 10 seconds. Okay. You're going to get to the point where you see a pacer spike and then a QRS following. Once you have a pacer spike and a QRS after every pacer spike, you've now reached capture. Okay. At that point, turn it down by 10. You'll lose capture, then turn it back to where it was. As long as you recapture again, okay, that really is my capture point. Now I'm going to turn it up 10 more. And the reason you turn it up 10 more is to give yourself a little bit of buffer, because just a little bit of distance in the pads can be enough to mean I might lose capture if I'm right at that point. So we go to roll the patient to put them on the stretcher, something like that. That may change the distance in the pacer pads just enough that we lose capture. And so that extra 10 milliamps gives you a little bit of a buffer there. Okay. Obviously, again, not as big of a problem for us, but transport to a facility that has a cath lab. The reason for that is if this is something where they're going to need a permanent pacemaker, cath labs are who put the permanent pacemakers in. I can do, and most emergency departments are theoretically capable of doing a temporary external pacer. So we fish wires down into their heart and hook them up to a pacer box on the outside of their body. But we try and avoid doing that, if we can, especially if we're getting good capture with pacer pads themselves. Okay.
You fish wires down into their heart. I'm just kind of curious here.
First, you take a deep breath. The last step in it is you change your underwear. Essentially, it's like us starting a central line.
Putting this through like
Yeah, so you typically are going to go through the right internal jugular or the right subclavian, and you're going to put in what a lot of like trauma surgeons will put in, which is a cordis. It's the big pipe that then has the small little thing off to the side. That big pipe at the tip of it has actually it's like a one-way valve. Okay, so you can actually put other things through that. So a lot of the time they'll put a central line through it. Okay, but in this case we're going to put these pacer wires through that. And essentially you feed it in. I love the dog's commentary. Essentially, you feed it in until you're in a certain amount. You inflate a balloon, okay, and then that balloon is supposed to get carried down into the base of the right ventricle, okay. And once you get down into the base of the right ventricle, you should be seeing on your EKG at this point, hey, I've got electrical activity on the end of my lead. Now I can, start seeing if I can get capture with it. So I have had to do it 3 times. It's technically not difficult, but it is sure a pucker factor.
I was envisioning you sticking needles in your chest and like.
Oh yeah, no Pulp Fiction. That would be too much fun. So, all right. So now we're going to split the tachycardia stuff into the way that our protocol reads. So yes, go ahead.
You did say if you confirm a type or a complete heart block, we don't pace, right?
Correct. Yeah, because the atropine really isn't going to do much. The push dose epi might help. But even then, if you've got somebody who's in a complete heart block, you're pretty much going to have to start pacing them. So
You do pace.
yeah,
Yeah.
yep, yeah, because unfortunately, the drugs are likely not going to have any effect. So we're going to go through this the way the protocol is written. Wide complex tachycardia that's unstable. So this is somebody who's got a ventricular rate of over 150, and they've got signs of poor perfusion. Altered mental status, chest pain, shortness of breath, low blood pressure, etc. Take a look at their 12 lead. They've got to have wide QRS, so that's more than 3 small boxes. Okay. Really, I honestly should have absent P waves. Okay, because at this point the P waves aren't getting transmitted clearly because it's wide complex. We want to initiate IV access, get that 12 lead, and then initiate rapid transport. Okay, so this is essentially the unstable VTAC. All right, while we're on the way, we need to determine whether or not this is torsades or not. If it's torsades, we're going to give them magnesium sulfate. 2 grams IVIO diluted in at least 10 milliliters of normal saline, and you administer that over 10 to 15 minutes. Typically, if it truly is torsades, very shortly after you begin kind of pushing a milliliter a minute, you're going to start to see improvement of that. Okay. The QRS complexes will narrow up, and hopefully the tachycardia will begin to slow down some. If it truly is VTAC, though, we want to try and sedate them if we can. But again, if they're truly unstable, we think that they're going to arrest here soon, etc. It is perfectly appropriate to just warn them this is going to suck, and then shock them. Okay. Because this has a pulse, you want to try and hit the sync button. Okay, and then you're going to cardiovert them. So you start in adults at 100 joules, and then you can work your way up by 100 joules each shock, all the way up to the maximum 360. Okay. If you can sedate them, go ahead and give them the Versed as we discussed earlier, so that way they at least have no memory or a foggy memory of it. Okay. If you've never cardioverted somebody who is semi-conscious, they may look asleep. You shock them, their whole body shakes, and they may go, and then immediately go back out. That's kind of the goal of what happens. Okay. Obviously, if that breaks it, get a 12 lead so we can see. It may be that this person's having a STEMI. It may be that they've got something else going on. If the ventricular tachycardia occurs again, you're going to shock at whatever was successful the first time. You don't start back at 100. You just go with whatever worked the first time. Okay. So let's say we've got a wide complex tachycardia that's stable. So we have somebody who, maybe it looks like VTAC, but they're talking to you. They're like, yeah, I'm a little short of breath, got some palpitations, that kind of thing. These are the folks that we have some time to potentially give them medication first. So obviously we want to get their pacer pads on, because it may be that they end up developing instability and we need to shock them. But get a 12 lead EKG on them. If it's torsades, treat it as previous. And then you can consider giving adenosine. Okay. You start with 6 milligrams, then you give another 12 milligrams, and you can consider giving a second 12 milligram dose. Okay. We're going to show you pictures here in a minute of how I personally recommend giving adenosine, so that way it's most successful. You can consider giving amiodarone, 150 milligrams IVIO over 10 minutes if the tachycardia persists despite that, okay? And you can repeat that 3 to 5 minutes after the infusion is done, all right? Obviously, if the person becomes unstable at any point, you revert to that protocol, which is you're pretty much going to shock them, okay? So let's talk about adenosine. Did I skip a? Nope. All right. So let's talk about adenosine. So this is a video of pinched tubing. So we're going to go over a couple different methods of giving adenosine. If it'll work. All right. Well, the goal of these videos was to show you that really, if you've got a wide open line, okay, it's flowing in really well. All you need to do is pinch above the port that you're going to infuse the adenosine into, push the adenosine into the tubing, and let go. Okay? That is how you're going to rapidly flush it in. If you've got a line that maybe isn't flowing so great, you're going to have somebody squeezing on it or use a pressure bag. So that way, it is going to have a pretty rapid flow rate. Any of the other ones where have to do a syringe push, of a flush, or you do a three-way, et cetera, you're not really going to get the concentration of adenosine that you need. That's a lot of the time why the 6 milligram dose doesn't work. It's because it needs to get there all at the same time. If you split it up by just a second, you're really getting like 3 milligrams and 3 milligrams instead of 6 milligrams all at the same time. So I've gotten completely away from the stopcocks and from the actual flushes, et cetera. And what I do is, have a wide open flowing line that I inject the adenosine into one of the ports with, and the line itself flushes it in rapidly. So you're getting it all at once. Okay. So how does adenosine work? Well, it's a short-acting antiarrhythmic. This is actually part of your body already. So this is a nucleopeptide that your body actually uses to make proteins, et cetera. Interestingly, it depresses SA node and AV node activity. Okay, so it essentially stabilizes the membrane so that they're not sending that electrical impulse as rapidly. Okay, and by not sending the impulses rapidly, we then are going to slow down the electricity getting to the rest of the heart. So it stabilizes this membrane, hopefully slows things down enough that that cycle can break. Okay. So let's talk about narrow complex tachycardia. So this is our patient that's like SVT. Okay, so they're SVT, they're otherwise stable. Again, I'm a little short of breath. I have some palpitations, et cetera. But, I still have a normal mental status. I'm still talking to you. I can tell you how I'm doing, et cetera. So pulse of 150 or more, systolic blood pressure of greater than 90. Typically, you'll be able to identify that these have a regular atrial rate. You may not be able to see a P wave, but you can tell that it's very regular. Okay. That almost always means it's coming from the atria instead of lower. They typically are going to have a nice narrow complex QRS, so less than 3 little boxes. Um, First step is, of course, put the patient on the monitor, get a 12 lead EKG, get pacer pads on them in case it does become unstable. And then you want to try and have the patient perform the Valsalva maneuver. And there's a bunch of different ways that people, have said to try the Valsalva maneuver. The easiest one is you just have the patient bear down really hard, okay? And you tell them that this is you're bearing down hard like you've never borne down before, okay? You're going to push with all your might, etc. The other thing that I've had success with is you have them put their thumb in their mouth and you say, all right, I want you to imagine that your thumb is a balloon and you're trying to blow up your balloon, okay? And so that will cause them to do it. The other thing that I've seen is you get whatever small syringe you've got and you say, I want you to blow out through this really small syringe, okay? All of those will stimulate and hopefully break the cycle. If that, of course, doesn't work, I've only had it work, honestly, a handful of times. I just personally seem to have horrible luck with it. I know lots of people, though, that have great success with it. I don't know what their magic sauce is, but, I've just not had a lot of success with it. You're going to then administer the adenosine 6, 12, and 12, again, via whatever method you're going to use. So if this person now becomes unstable, so they're now showing signs of inadequate perfusion, their blood pressure is less than 90, and they don't have any history of trauma or fever, then this is probably cardiac to begin with. So the reason we say no trauma, no fever is this may be compensatory tachycardia, okay? If you have just been schmucked by a truck and have a heart rate of over 150 and a blood pressure that's in the toilet, the primary problem is you got schmucked by a truck, okay? And the reason you're tachycardic is because you're bleeding. So giving this stuff is actually going to hurt the patient, okay? Same thing with fever. It's very reflexive to, oh my God, they're an AFib RVR or they're, an SVT and they got 103 temp. The reason they've got a heart rate like that is because they have 103 temp and are septic. So the initial treatment in those patients is going to be fluids. We want to see if we can get this person's heart rate to slow down. And my experience, that typically works. You start giving them sepsis fluid boluses, et cetera, and their heart rate begins to improve. It may be that, you only can get them slowed down by 30 or 40 beats per minute, but that's 30 or 40 beats per minute, okay? It may be that once they get to the hospital, we have to do more medication, but you've already essentially begun to fix the problem, as it were. If this person, though, truly is having cardiac cause, okay, so they have inappropriate tachycardia, and they're unstable, then we're going to need to probably cardiovert them. So sedate them again as able, and then synchronized cardiovert them. The protocol spells out that if this is AFib, you're going to cardiovert them with one set of energies and everybody else you do with a different set of energies. I don't like that so much because that relies on you remembering like, oh, is this 100 or 120? It's like the 20 joules is not going to make that much difference. Okay. So, I would stick with the 100, 200, 300, 360. Okay. It's just one less thing that you have to try and remember. So again, you're going to increase those stepwise. You've got to make sure that you hit the sync button before you cardiovert them to make sure that that's effective. So that's the end of part one.